Well, good day, everybody. This is Chris with the Ancient Scholar. I hope this video finds you all doing well today. So in this video, I'm going to kind of return to a more traditional video format and focus on providing some more traditional medical content. And so what I'm going to be doing is I'm actually going to be returning to a couple of videos I did, it was about a year or so ago, where I focused on what I would call oncological urgencies or even oncological emergencies. And there aren't a whole lot of like truly acute, imminently emergent oncological specific conditions aside from sepsis, severe sepsis, and septic shock, which is a big problem with people who are being treated for oncological conditions. But sepsis, severe sepsis, and septic shock is not necessarily specific to the oncological milieu, whereas something like tumor lysis syndrome is actually a true oncological emergency. And so in this particular video, I'm going to talk about something that the time frame is in weeks or a couple of months as far as survivability goes. But still, if you suspect this is occurring, this should be treated as a true acute medical emergency, which is, again, not super common in the oncological milieu. And to make it even more challenging, the workup is generally very complex in the oncological patient and really kind of goes well outside of the standard operating environment of a pre-hospital provider. And that's kind of where a lot of my content is focused, on the emergency and pre-hospital situations. But I think I have a condition that, at least to some extent, can be appreciated, suspected, in the pre-hospital setting. So I want to spend some time talking about that. And that specific condition is something called blast crisis. Blast crisis is a condition that is almost always, not always, but I would say almost always associated with a very specific type of cancer. In this case, it's a type of cancer called CML, or chronic myelogenous leukemia. So leukemia is a type of blood cancer. It is a cancer broadly that impacts the hematopoietic system, and you have abnormal cell division involving the blood stem cells. And there are, when we talk about your blood stem cells, your hematopoietic system, just to basically conceptualize what's going on, you have these initial stem cells, these progenitor cells, that then are acted on by hormones and other chemical messengers that go into the nucleus of those cells and activate genes that cause them to divide and to differentiate. And those blood stem cells can differentiate into two major lines of cells, the myeloids and the lymphoids. And so these blood stem cells in the bone marrow can differentiate into myeloid stem cells and lymphoid stem cells. And then the myeloid stem cells can further subdivide into other cell types. Specifically, when talking about the myeloid cell line, they can differentiate, the myeloid stem cells can differentiate ultimately into erythrocytes, or red blood cells, megakaryocytes that then become platelets or thrombocytes, and then the myeloblasts. And then the myeloblasts, so you've got the blood stem cell, the myeloid stem cell, and then the myeloid stem cell can, ultimately become red blood cells, thrombocytes or platelets, or these myeloblasts. And then the myeloblasts can mature into what are called the granulocytes, and these are types of white blood cells. And there are three granulocytes. There are the eosinophils, the neutrophils, and the basophils. Now, on the other side, the lymphoid stem cells will become what are called lymphoblasts, and they will mainly differentiate out into the agranulocytes, so the B lymphocytes, the T lymphocytes, and the NK or the natural killer cells. And so CML, chronic myelogenous leukemia, is a leukemia that involves primarily the myeloid lineage or the myeloid cell line, right? So that's the basic problem. CML is typically a cancerous or an oncological condition that involves older individuals. Not always, but generally speaking, people beyond the age of about 50 are people that tend to develop CML. I believe the average age of diagnosis is between 50 to 60. Okay, so middle age into late middle age is where most people start developing this. As far as leukemia goes in adult patients, you're looking at about 15 to 20% of all leukemias in adult patients will be CML. So CML is not an uncommon form of leukemia by any means. Now, about 90% of the time, so 9 out of every 10 patients who have CML will present with what's known as the chronic phase, which is a very slowly progressing disorder, all right? And so what happens is there is abnormal cell division involving the myeloid cell line. And so essentially what you get is you get an abnormally large amount of immature myeloid cells being produced, the myeloblasts, all right? And those myeloblasts are not differentiating into the mature functional white blood cells, the granulocytes, the eosinophils, the basophils, and the neutrophils. And so you have a relatively slow and progressive increase of these myeloblasts. And a blast in cytology, cytology is a study of cells, a blast is just a broad term for any sort of immature cell type, right? So a lymphoblast would be an immature lymphoid cell, a myeloblast, immature myeloid cell lineage, okay? And about 90% of the time, this is a fairly slow, chronic, progressive disorder, okay? And prior to the advent of modern therapeutics, this ultimately would be a fatal disorder and would substantially impact the quality and quantity of life that people had. But now that we have, within the last few decades, we now have specifically tyrosine kinase inhibitors, imatinib being one of the primary agents that are used. That is actually a very effective therapeutic for this type of leukemia, CML, and we see people with CML who go on imatinib tend to have a fairly long life, and the lifespan, the quality and quantity of life is roughly on par with people that don't have CML. And so this is actually probably one of the, in contemporary times at least, this is probably one of the most notable and profound successes in heme oncology is the advent of imatinib as a gold standard therapeutic. And we don't often see something as successful as imatinib in the hematological oncological milieu. That said, however, about 10 to 20% of people with CML will develop what's called an accelerated course. They'll go from chronic to accelerated. And in the accelerated course, what happens is they have faster than normal production of these immature myeloblast cells. So in CML, 10% or less of the blast when we look at your blood and we do a smear of the blood and we look at it under a microscope, less than 10% of the cells that we see that make up your blood should be these blast cells, these immature cells. Once that goes above about 10 to 20%, we now say that the patient has entered what's known as the accelerated phase of CML. Because these myeloblasts are technically white blood cells, they're dysfunctional white blood cells, but because they are white blood cells, this will often manifest as a marked or as an increase in the white blood cell count on the CBC. So you'll have a leukocytosis generally greater than about 20 on your WBC, or 20,000 cells, okay? And this will remain elevated. So there are lots of things that can cause a leukocytosis, mainly infections and things like that, but this will remain elevated despite standard treatment. In addition to that, what starts happening is you start having increased numbers of all of these other, like thrombocytes, for example, being produced that aren't very functional. And you have essentially a functional thrombocytopenia, where you might have enough platelets, but the platelets you have are not functional. And then you start developing coagulopathies where you may have trouble clotting, or you may be more prone to clot, and you can develop clots more easily, all right? So that's kind of what we see in the accelerated. And then there is, I think it's somewhere around 10% or so of people with CML will develop what's called the blast phase of CML. And essentially the blast phase is basically like acute leukemia. This looks a lot like someone who has acute leukemia, where you have very rapid cell division and you have a very rapid and marked production of these blast cells. Generally, this is going to be greater than 20% blasts when you look at a smear of blood, when you look at a blood smear, or when you look at the bone marrow, when you get a sample of bone marrow. And this is a situation that is generally considered an emergency, and we call this blast crisis. So when somebody with CML starts producing massive amounts of blast cells very rapidly, uncontrolled, and they are not responding, they are refractory to the standard therapy for CML, which again tends to be a tyrosine kinase inhibitor like imatinib. All right, so blast crisis should be considered a life-threatening hematological emergency that results from a marked and rapid increase in blast cells within the bone marrow and the blood itself. And that results in a lot of dysfunctional cells. So your red blood cells are not going to work, your platelets are not going to work. And then you have large numbers of white blood cells that are being produced, but they're dysfunctional, right? And this can cause your blood to become hyperviscous, right? We call this hyperviscosity, where you have all these cells that are in your blood, and it's harder for your blood to move around due to that viscosity. That can impair perfusion to the brain, to the heart, to the lungs, and other vital organs. And so these patients can present with stroke-like signs and symptoms, with difficulty breathing, cardiovascular symptoms, hepatic symptoms, liver dysfunction, kidney dysfunction, and typically they will also have swelling of their spleen, or what we call splenomegaly, okay? And so that's kind of what we see. Clinically, what we see, what you're going to see is a patient with CML, okay? So you have to kind of know that, dig into their history, and they have essentially, they present with signs and symptoms of pancytopenia. Pancytopenia just means a decrease in all the cells in your blood. How can that be? Well, they have a functional pancytopenia. So even though they're cranking out lots of blood cells, the absolute number of cells in their blood is actually very elevated, but the actual number of functional red blood cells, functional platelets, functional white blood cells is very low. So they have this pancytopenia appearance where they, they may be pale, they may feel like they don't have any energy, they feel very run down. They look like they're anemic, they're at high risk for infection. They have typically will often present with a fever that doesn't go away, with an elevated white count that doesn't go down. And that's the kind of clinical picture that we see. And this will develop fairly rapidly over a period of several days to some weeks versus months and years, which is the typical progression that we would see with CML. All right. So when they enter blast crisis, you have this critical increase in these circulating immature blast cells, and that leads to blood hyperviscosity. You have decreased tissue perfusion of the vital organs. You look very pancytopenic, and these patients present with signs and symptoms that look like that. They're anemic, neutropenic, thrombocytopenic, right? So they're more prone to clot. They're more prone to bleed as well, all right? And the myeloid compartment expansion due to these myeloblasts being cranked out will actually start to crowd out other stem cells and prevent normal blood cells from being produced. It essentially crowds things out, if you will. And some people refer to this as the white cells not moving, right? So you may hear terminology associated with that, and that is occurring relatively speaking, all right? So the symptoms tend to be very vague, but they look like pancytopenia. So this is a patient that is complaining and feeling very weak, very fatigued. They often will have abdominal fullness, splenomegaly, fever that doesn't go away. They tend to lose weight fairly rapidly, so a fairly marked and rapid loss of weight. Night sweats and chills are very common. And you also have, basophils that are being produced that are releasing histamine. And so pruritus or itching all over is relatively common. Respiratory failure, congestive heart failure, myocardial infarction, and stroke-like signs and symptoms are not uncommon due to the decrease in perfusion and the impairment of the microvasculature due to clot formation, hyperviscosity, and things of that nature. All right. The most common cause of death in people that go into blast crisis is actually infection, as you might imagine, and that's again secondary to this, essentially this functional neutropenia that they have. The second most common cause of death is fatal hemorrhage, mainly due to the loss of functional platelets or the functional thrombocytopenia. So you get called, right? You get a 911 call as a paramedic, and you're assessing somebody that has a history of CML. These are the red flags that you want to be looking out for to prompt you to think about the differential diagnosis of a blast crisis. And then you convey that to the receiving facility, plant that seed so they can then investigate further and institute the appropriate management. So essentially, the initial emergency management of this is aggressive resuscitation. So if there are any signs and symptoms of infection, these individuals are going to need antibiotic therapy. And because fungal infections are more likely to occur, you may actually want to strongly consider appropriate antifungal coverage as well. All right. Anemia, however, needs to be treated very cautiously. So normally, if someone is anemic, they're critically anemic, we would consider a blood transfusion, transfusing blood products. The problem with giving somebody blood products in blast crisis is their blood is already fairly hyperviscous, and adding more blood to the mix may actually make things worse. So the administration of packed red blood cells may actually worsen the crisis. And so you would generally want to hold off on aggressive blood product transfusion until you have gotten in touch with a heme-oncologist that knows how to deal with blast crisis and gotten some guidance there. All right. So that's another important component, is getting the patient to the appropriate level of care, right? Getting them to appropriate heme-oncology level of care. And then there is, of course, laboratory investigations that need to be done. Not only are you going to do a septic workup on these patients, but you definitely are going to need to get a CBC with a manual differential. You're going to want to get a blood chemistry to look at their electrolytes, look at how their kidneys are doing, look at how their liver is functioning. Okay, you're going to want to get a coagulation profile, a PT, PTT, see how coagulopathic they happen to be. And so that's kind of a good starting point for the diagnostics, the diagnostic workup of these patients, and then again, early management with a broad spectrum antibiotics, and following up with possible antifungal coverage as well is going to be important. So what are the main takeaway points? Again, the most common complications of a blast crisis are going to be those pancytopenic issues, the anemia, the functional anemia, the functional thrombocytopenia, so bleeding, infection, sepsis, severe sepsis, and septic shock. All right. So if the patient has concerning symptoms, they have a marked leukocytosis, we're worried about hyperviscosity of the blood, we need to have an emergent heme-oncology consult, or transport the patient to an appropriate facility that can provide that higher level or subspecialized heme-oncology level of care. So that's the basic rundown of blast crisis. The last thing that I just want to talk a little bit about is the more complex pathophysiology, and this is going to be more relevant for maybe some of you who are in nursing school, maybe even med students, not so much paramedics, but this is still, I think, kind of interesting information and might possibly be relevant on your individual board exams. So I'm going to talk about the in-depth pathophysiology, because CML is a fairly well-studied disease process, and as far as the genetic component goes, we actually have a fairly reasonable understanding of the genetics, and that should make sense because we have fairly good therapeutic agents like the tyrosine kinase inhibitors. So we know that CML tends to occur following the acquisition of a genetic abnormality. So essentially what happens is you have mutations that occur in the nuclei of the stem cells. And these mutations, the risk factors for these mutations tend to include people that have had a history of myeloid leukemia in the past. They have exposure to ionizing radiation, significant chemical and alkylating agent exposure in the past, cigarette smoking, and a history of immunodeficiency diseases. So think of HIV, think of the autoimmune diseases where people are receiving immune modulating medications, right? So systemic lupus erythematosus, rheumatoid arthritis, and so on, and organ transplant, HIV, things of that nature, are risk factors that increase the likelihood of these genetic changes occurring. So essentially what happens is there's an acquired genetic abnormality that occurs, and there is a new gene that gets formed. And this new gene is referred to as the BCR-ABL proto-oncogene, right? So this is a gene, a proto-oncogene, that if activated will then lead to the production of these abnormal blast cells, all right? And so what happens is there's actually a translocation of that gene between chromosome 9 moving over to 22. And when that gene translocates over to 22, gene 22 is now altered, if you might imagine, and this is actually referred to as the Philadelphia chromosome on gene 22. And that's, particularly if you're like a nursing student or a medical student, this is like something that you need to associate with CML, right? You need to associate the BCR-ABL proto-oncogene, the translocation of that gene from 9 to 22, producing the Philadelphia chromosome. That's knowledge that you need to attach to CML, all right? And so what happens is if this oncogene if this proto-oncogene then actually gets expressed, right, actually gets read, right, and turned into a messenger RNA, right, gets transcribed and then translated into protein, and causes cell division, that's when it becomes an oncogene. You have an unstable genome within the nucleus of that stem cell, and that stem cell starts dividing, and you have this proliferation of these immature and essentially non-functional myelogenous blast cells. And if this occurs rapidly, that's what leads to a blast crisis, all right? So that is the more complex pathophysiological basis behind CML in general. And then when this process occurs very rapidly, that can lead to accelerated CML and even blast crisis. All right, everybody. I think that's everything I want to talk about there. I know this is probably a bit on the longer side, but I find this to be a very interesting concept, and it is an emergency condition. You're looking at, if people go into a blast crisis, you're looking at the median survival rates of a couple months, like 2 to 3 months survival in people that go into blast crisis without treatment. And even with treatment, the prognosis is generally not great. People can live a year or more in many cases with your treatment versus a couple months. But these patients tend to be very sick, very difficult to treat, and they're refractory to the primary treatments, and they tend to require more aggressive chemotherapeutic regimes and possibly even stem cell transplants to try to prolong quality and quantity of life. And in some cases, the blast crisis can be so severe that instead of treatment, the discussion might shift into talking about palliative care, end-of-life care, and things like that. All right, everyone. Thank you all so much. I hope you enjoyed this video, and we'll see you in the next one. Take care.